Yes, I would really like to know your views on use of vasoactive medicines in neonates, especially premature neonates, like resource
Again, we
limited
are talking of
settings.
resource limited settings. So one important thing is that there is a lot of information that people are aware. For example, most of you are starting milrinone directly for PPHN. And PPHN is one of the most difficult diagnoses in a resource limited setting because you don't have nitric oxide, and then the question of sildenafil, no response to sildenafil, you start milrinone. But again, you may not have the support with echocardiography available because hypotension is very serious. And obviously, it can cause shutdown of multiple organ systems, and you may start a vicious cycle where the baby continues worsening. So trying to fix a problem, you may end up creating another problem. Even in birth asphyxia, for example, PPHN is common. Meconium aspiration is linked with both. So I've seen many of you starting milrinone with a low threshold. So I would suggest to be careful with that. Make sure you have optimized your ventilation. And if you can't manage the baby suitably, start thinking of referring them to a suitable center. And if you don't have focus, using the appropriate vasoactive medication becomes challenging because you have to look at the right ventricular function, right left ventricular function. Nitric oxide may worsen left ventricular failure if it's a left ventricular dysfunction. So you need to be able to titrate your treatment. I know you can go with the saturation, blood pressure, and so on, but the risk is high, and you may have to start medication like norepinephrine along with milrinone if you're starting, just to make sure the blood pressure doesn't drop. And in a team which is not routinely using these medications, preparing them, calculating them, many chances of drug errors. And dopamine or dobutamine, if you start also, the response cannot be predicted immediately. So always try to use it only if it's essential, and you look at other reasons for why a baby may have problems. If the blood pressure is low, check if your cuff is appropriate, whether the temperature, we talked of golden hour management. So right from the beginning, temperature care, fluid management, appropriate ventilation. So not overdoing ventilation is important. Giving surfactant and not weaning the ventilation may lead to over distension and iatrogenic PPHN. And the saturation targets, weaning the oxygen appropriately is important as well. So remember to prevent the problem, and if prevention of infection is a common factor as well. So prevention of infection. I also see a trend, many of you are treating PDA with paracetamol without doing an echo. So remember that there are duct dependent lesions which you may miss, and obviously it can be life threatening. And most of the babies, the bigger babies that you're managing, such units don't really need PDA treatment. So the PDA treatment, most of the cases need only below 28 weeks, which most of you will not be handling. So having a murmur day 2 to 3 and having the access to paracetamol doesn't mean you need to take the risk of treating with paracetamol without an echo. I know paracetamol is safe, but it's not necessary, and closing the duct may change your hemodynamics in those babies as well. So I know some of these babies may need, in terms of PDA management, only 10% of the babies above 28 weeks are likely to need some treatment, which is a very small number, and 30-40% would have a murmur. So always get a echo. Maybe it's a closing PDA and you don't need to start any treatment. So my advice on vasoactive medications is to be careful. Try to again invest in focus. If you are going to ventilate a baby, if you are going to manage hypotensive babies, or you're planning to cool babies in your unit, always get ultrasound at the same time, because all these are linked. And focus could help, not just lung ultrasound, but echocardiography. So when I said earlier that you have to learn to walk first before you run, I mean that you should have all these before you think of ultrasound. But if you have all these, you should have the ultrasound as well. Hopefully, it's not essential, but it's much better. And having managed both sides, I mean, with and without, it makes a big difference to be able to assess hemodynamically. And all the guidelines you get these days is looking at